The record. Okay, got it. All right, perfect. So let's go over this stuff. So cortical functions. Can you see this okay?
Yes.
Okay, great. So with cortical functions, we're going to basically break down everything with the cortex. We're going to break down the different lobes of the brain. We're going to break down what each lobe does. And at the very end, I'm going to give you these papers, or not papers really, right? Because they're slides. These slides that have each one of the lobes, right? Frontal lobe. What functions does the frontal lobe have? The parietal lobe. What functions does the parietal lobe have? Occipital lobe. What functions does the occipital lobe have? So you'll be able to use those as cheat sheets when you're doing questions on cortical functions. And the big way they're going to test this is on artery supply. They're not going to ask you straight away, like, what the heck does the frontal lobe do? What does the prefrontal cortex do? What does the frontal eye field do? They're not going to ask you like that, right? They're going to have a lesion and they're going to ask you various questions like, what do you expect to see next? What do you think is the artery affected? You know, they'll give you the symptoms and then ask you what artery is affected. So that is the tie-in with vascular that we're going to talk about on Saturday.
Okay.
Okay. But this is the stepping stone for that because after you know this, the vascular is just okay, what artery supplies this area now?
Okay.
Okay. Great.
Mhm.
Now, this is the actual brain, right? You have various divisions of the brain. It's hemisected in half with the sagittal sinus going down, right? You have this sagittal sinus here. You have the sagittal sinus here that separates the frontal from the temporal, right?
Mhm.
And then you have the longitudinal sulcus that separates the right from the left hemispheres. Okay. Now, with that being said, the body itself is then split into right and left because you have two hemispheres, right? So the right hemisphere takes care of the left side of the body with motor and sensory. The left hemisphere takes care of the right side of the body with motor and sensory. What is different is language. Why?
Um,
So language is always going to be on this left hemisphere. Okay? That's where language is going to be located at. Always the left hemisphere with Wernicke's and Broca's.
yeah.
Okay? And then on top of that, the opposite hemisphere, the right hemisphere, has the same areas, but they're not as important as the dominant hemisphere, which is the left hemisphere. Even in left-handed people, the left hemisphere is the most dominant. Okay.
Okay.
Usually it goes by whichever hand you use the most. If you're right-handed, it's the left hemisphere. If you're left-handed, it's the right hemisphere. Uh, Left-handed people are still left hemisphere dominant. It's just that some portion of left-handed people can be right hemisphere dominant. Okay. So ultimately, it depends where language is located at.
But you
Okay.
said language is always on the left.
Yes, language is always on the left because the majority of the people are right-handed. So they're left hemisphere
Oh,
dominant.
that's what you mean by it's like opposite?
Yes.
Okay.
Yes. So they're more often to be left hemisphere dominant because they're right-handed. However, you can get people who are left-handed dominant and they have it on the right hemisphere. Okay. But even those people who are left-handed, majority of them are still left hemisphere dominant.
Okay.
Okay. And it's just because of how the language is snug into the left hemisphere. All right.
Mhm.
Perfect. All right. Now, with that being said, you do have certain separations of the cerebral cortex. I'm not going to talk about that. I'm not going to worry about that. Now, let's move on. So, from the cerebral cortex, the next thing that's very big is the corpus callosum.
Mhm.
Can you tell me the function of this guy? What does he do?
I'm actually not sure.
So the big function he does is that he allows the hemispheres to communicate with each other. This is something that you need to know
Okay.
because there's an actual issue later on that you'll see things like alexia without agraphia. You've heard of that, right?
Agraphia, yes. Alexia, no.
So alexia is reading,
Okay.
okay? Agraphia is writing, right?
Right.
So alexia means you can't say something out loud. Agraphia means you can't write it. Okay.
Okay.
So there's
Mhm.
people out there that can read something, right? Or no, my bad. They won't be able to read it, but they can write it. So that's what the alexia,
Oh,
unable to read without agraphia, able to speak though. And we're going to talk about that.
okay.
Okay. All right, perfect. Now, here is the layers of the cortex. You get various layers. There's 6 layers in the neocortex, which is the more mature portion of the brain. And there's only 3 layers in the allocortex. Now, in the allocortex, there's only 2 big places that you need to know. That's the hippocampus and the olfactory cortex. Okay? Now, these layers do different things. I've never seen a question that asks me about what layer it goes to. Never.
Okay.
I've never seen a question like that. But does that mean they're not going to make one? No. They can possibly make one. So I'm going to tell you. First layer is mainly nerve fibers. Okay? Nothing is really going on here. You're just moving information. Second layer, nothing really going on here. It's just cell bodies. Third layer, this is the guy that's responsible for projecting to other parts of the brain. Okay?
Mhm.
Fourth layer, this is where you get information from the thalamocortical projections. So this is things like touch, pain, proprioception, things like that. Okay? Coming from the thalamus, going to the cerebral cortex. The last one is the internal pyramidal layer, these pyramidal cells. This is responsible for the cortical bulbar and cortical spinal tracts.
Mhm.
Okay. A good way that you can remember it is that these pyramidal cells, they release glutamate. And what you know already is glutamate is an excitatory neurotransmitter. Okay.
Mhm.
And as such, when you get excited, you move your muscles. So that's what this guy is used for. Okay. Now, stellate neurons, these are the non-pyramidal cells that you see here and here. These guys release GABA. Okay. And
Okay.
GABA is the guy that helps with inhibiting transmission, right? Now, what's the inhibitor in the spinal cord? Do you remember? We went over it.
Mm,
Starts with a G, comes from the Renshaw cells. Glycine.
oh,
Glycine is the inhibitory one in the spinal cord.
mhm.
Okay. Those are the only 2 inhibitory ones that you have to worry about. GABA in the brain, glycine in the spinal cord. Okay, great. Now, here's looking at the various lobes. There's a whole bunch of them, right? Because now we're taking the actual cortex. We saw the cortex. Now let's split that up. Now you know there's lobes to the cortex, right? You got all the various lobes, and you know that. I'm not going to harp on it. So let's move on. Now, these various lobes have various functional areas. Okay. For instance, in the frontal lobe, you got that lovely frontal eye field. Do you remember that guy?
Yes.
What does he do?
Um, just allows like whatever you see to go to the retina.
Mm, so remember conjugate eye movements we talked about?
Uh-huh.
You got the frontal eye fields that allow whenever my left one gets stimulated, it moves my eyes conjugately to the right. If my right one gets stimulated, it moves my eyes conjugately to the left by using the MLF pathway that we talked about,
Right. Okay.
the medial longitudinal fasciculus,
Mhm.
right? Okay.
Mhm.
So what happens when you have a lesion of the frontal eye field?
Then you're not able to turn your eye medially or like the one that is
So not
damaged.
the so not the MLF. I'm thinking of frontal eye field. You're right if it's the MLF, right? Whichever eye can't adduct is the side that MLF is damaged on, right?
Mhm.
But frontal eye field is different. It uses MLF, but if you damage frontal eye
Maybe
field,
the superior colliculi and then it um like there's a problem with cranial nerve 3. Is that the one you're talking about?
no. So if you damage your frontal eye field, what happens is this. The right frontal eye field will overpower the left. So what
Um,
will happen is your eyes will slightly start to turn towards the lesion
mhm.
because your left one isn't able to power the eyes back to the center.
Okay.
Okay. So that's
Mhm.
what happens with frontal eye field lesions. Okay. Now, the prefrontal area is also in the frontal lobe, and we'll talk about that. And then the motor area being Broca's aphasia. Or Broca's aphasia, we'll talk about that also later. Now, that's the frontal lobe. Outside of the primary motor cortex and the premotor area. Okay. When we say premotor, is that initiating or planning of movement?
Planning.
Perfect. Planning of movement. Now, from there, you go on to the parietal lobe. On the parietal lobe, you got essentially three big things. You have the primary somatosensory cortex, you have the somatosensory association, and the angular gyrus that has portions of the Wernicke's area there. Okay. Now, do you know anything about the somatosensory association area?
Um,
So these areas, all of these association areas, what I want you to think of is this. Information comes in. It goes to the actual cortex first, right? Primary motor cortex, primary somatosensory cortex, primary auditory cortex, primary visual cortex. It goes there first to process that information. Okay.
okay.
Then it takes that information and integrates it with the rest of the brain via the association area.
Okay.
Okay, so for instance, let me give you an example. If I had a lesion of the somatosensory association area, would I have an issue feeling things?
No.
No, you do not have an issue feeling things because that's the primary somatosensory area, right? But you do have an issue communicating with the other parts of the brain to know what you're touching.
Oh, okay.
Okay.
Mhm.
That is what I mean.
Okay.
All right. Now let's do another example with the visual area. Tell me what association area with the visual cortex, if you have a lesion there, what would they more likely present with?
Um, they'd be seeing something, but they wouldn't be able to tell what they're seeing.
Yes, exactly. Perfect. You're starting to get it, right? So it's the
Mhm.
same concept, even with the auditory cortex. You'd be able to hear things, but you wouldn't really know or be able to constitute what it was if someone was to ask you, well, what is that sound? I
Mhm.
don't know. I know I'm hearing something, but I can't tell you what it is.
Mhm.
Okay,
Yeah.
good. Let's move on. Now, primary motor area, contralateral body. We already talked about that, right? We harped on that when we did the basal ganglia,
Mhm.
right? It goes contralaterally. If you damage the basal ganglia, is it still contralaterally or is it ipsilaterally now?
It's ipsilateral.
No, still contralaterally. Because remember, the basal ganglia communicates to the cerebral cortex, which then sends it to the body.
Yes.
Okay. Because remember, the cerebellum is feeding into that basal ganglia,
Mhm.
right? It's feeding into the basal ganglia, which then sends that information to the cerebral cortex.
Okay.
Okay. So even if you have damage to the basal ganglia, it's contralateral. Ipsilateral is cerebellum.
Yeah.
Okay.
Mhm.
Good. Now, contralateral. Name me a few things when you see upper motor neuron. What symptoms is that? You should be able to
Uh,
just spit it out.
spastic
Spastic
paralysis,
paralysis. Okay. What else?
uh, Babinski sign,
Okay. What else?
hypertonia,
Yes. What else?
hyperreflexia.
Okay. What else?
Uh,
Do you get atrophy?
no.
Perfect. There you go. Nice job. So that's upper motor neuron symptoms. All those guys that you just talked about, all upper motor neurons.
Mhm.
Okay. So that's how you would present. Now, with that being said, it's broken up weirdly. It's not just here you go, all the neurons connect to all the parts of every muscle in the body. It's not that way, right? Certain neurons command certain muscles. Okay. So laterally, you have the face. Medially, you have the hips down. Okay.
Mhm.
Hips down. So that means urinary bladder. That means your bowel movements. That means your genitals, everything. Okay. Do not forget that because lesions can occur medially and lesions can occur laterally.
Oh
And
yeah.
this is how they present differently.
Okay.
Okay. Good. Now, premotor area. You already told me this guy's not important for initiating movement. He's important for planning movements.
Yeah.
This is why apraxia occurs if you have a lesion of this area. Apraxia just means you have impairment of planned movements, which makes sense because we already said that that's what it does. Okay. He's still able to move his muscles without any issues, but you tell him, hey, go out there and shoot a basketball. Oh, now it's a whole nother game. Okay. All right. Frontal eye field. I kind of alluded to that earlier. This guy, MLF, medial longitudinal fasciculus, lesion at this location. Both eyes look towards the lesion. Okay. MLF issue, you tell them. So in an MLF issue, normally their eyes are not moved to one side or the other. Their eyes are dead spot in the middle. Okay. In a patient that has MLF issues, it's when you tell them to look to the left or to the right is when you see the issue.
Right.
Okay. Good. Now, prefrontal cortex. I haven't talked about this guy yet, but he's big in personality. Okay. So, what makes you you? This is that Phineas Gage example that Dr. Glasser or whoever taught probably discussed, right? It's a huge thing because that was groundbreaking into this idea that certain areas of the brain contain certain portions of your personality or of who you are. Okay. But that's what the prefrontal cortex is all about. Now, that's the frontal lobe. Okay. There are other parts that I didn't touch on yet, which is the Wernicke's and Broca's, as well as arcuate and arcuate, which we'll talk on here in a minute. Now,